federal regulation of opioids. State regulation of pain management of opioids will be discussed this afternoon by several distinguished speakers. This presentation deals with the emerging patterns of federal regulation. Now, learning objectives, what we're trying to do is first explain to you what REMS are, risk evaluation and mitigation strategy for opioids. Second, mandatory education of prescribers, prescription requirements under the Controlled Substances Act, what constitutes illegal distribution, and some aspects of malpractice consideration. I had mentioned to you earlier about this, just to point them out. This is regulation. The policies include law, regulation, and guidelines. You've seen that before. What we hope will happen is that we'll have a balanced approach of the legal and the medical. And at the present time, unfortunately, we have the balance is in favor of law enforcement, and hopefully it might change. We talked about the important programs that the government has and the good medical practice. That was in my introduction, and mentioned to you about the 4 things that we have been discussing. So far, you've had primarily the education component. We're going to try to move into the medical legal aspect, and in the afternoon, it'll be primarily law enforcement and monitoring and drug disposal systems. Now, in 2007, the FDA Amendments Act gave the FDA the authority to require risk evaluation and mitigation strategy. The REMS programs are therefore FDA-mandated requirements to minimize the risk associated with certain medications. They require drug manufacturers to thoroughly educate healthcare providers and the public about their drugs. REMS may be required by the manufacturer prior to approval of a drug or post-approval of a drug if it becomes necessary to ensure that the drug benefits outweigh the risks. And risk may be mandated for pain medication or a class of medication. There are 5 different components of REMS listed on this slide, and those may apply to any drug REM. 2 of the 5 components, number 1 and number 3, are pertinent to prescribers. Component 1, the medication guide and patient package insert, are regarded as educational tools. Component 3, elements to assure safe use, or ETASU, includes special requirements, and there may be restrictions to optimize the treatment with the drugs. The elements to assure safe use of a drug may include training or certification of prescribers or pharmacists and pharmacies. There may be restrictions on where the drug will be dispensed. There must be evidence of patient safe use. There should be patient monitoring and enrollment of patients in a registry. Between 2008 and 2011, a number of opioids, as you see on this slide, received individual REMS programs. Each REMS approved drug has a trade name, as you can see, but several trade names may have the same class of opioids. Are these handled differently if they are of the same class? Let's take, for example, transmucosal immediate relief fentanyl opioids. These drugs include, as most of you know, Abstral, Actic, Fentora, Lazanda, and Onsolis. And these are obviously from different manufacturers. Will the manufacturers be required to provide separate and individual REMS to each and every drug product in this class? In December 2011, the FDA approved the first single shared system REMS for the whole class of transmucosal immediate release fentanyl, and that would replace the individual REMS for those drugs, and that'll be effective next month, March of this year. The prescriber can enroll once for all the products in this class, so you'll have only one website and one set of information to study. The goals of the TURF program is that the TURF medicines will only be given to those patients that need them, which will be patients who are tolerant. You prevent conversion of fentanyl. You want to be sure that's not going to happen, or expose children inadvertently, and to educate the prescribers, pharmacists, and patients about the potential for misuse, abuse, addiction, or overdose. On January 26, the American Society of Pain Medicine, ASAM, approved the mandated prescriber education for all healthcare professionals who are licensed to dispense or administer prescription drugs. ASAM further stated that very few physicians are sufficiently educated about the potential psychiatric consequences and addiction consequences, and that includes the opioid analgesics and sedative hypnotics. Well, how does a physician prepare for REMS? First, the physician should review his or her standard operating procedure and coordinate efforts in the office, clinic, and the pharmacy. Second, you must understand these federal and state regulations on prescribing opioids. REMS programs are in addition to, not a replacement for state and federal regulations. There are prescription requirements under the Controlled Substances Act. A prescription for controlled substance to be effective must be issued for a legitimate purpose by an individual licensed practitioner acting in the usual course of his or her professional practice. 3 criteria. There is a corresponding responsibility and duty on the part of the pharmacist who fills that prescription. A pharmacist may have a similar liability as the doctor. The DEA does not define nor regulate medical standards. There are no federal laws or regulations that put limits on the quantity of controlled substances that you prescribe. But states and insurance providers may limit the number of controlled substances that would be prescribed or dispensed. Now, here are 2 citations, one from the Controlled Substances Act and one from the Code of Federal Regulation, which state they acknowledge that controlled substances have useful and legitimate medical purposes, and practitioners are not limited in their ability to prescribe, administer, or dispense narcotics to persons with intractable pain. In 2006, the DEA reiterated its policy to prevent abuse and diversion without adversely impacting the legitimate need of patients to have full access to pain relief prescribed by their physician. The DEA reassured physicians that it does not apply a greater scrutiny to the prescribing of controlled substances to treat pain. As to electronic prescriptions of controlled substances, effective June 2010, DEA regulations provide the doctors the option of writing prescriptions for controlled substances electronically. However, electronic prescriptions are subject to 4 things. There should be an initial identity certification. There should be a 2-factor authentication. There should follow the standards as set by the Health and Human Services for transmission, and there should be no alteration of the prescription during transmission. Now let's turn to illegal distribution of controlled substances. What are the necessary elements? The necessary elements for illegal distribution are the defendant knowingly and intentionally distributed a controlled substance. Second, was not in the usual course of professional practice and not for a legitimate medical purpose. In 1995, in the case of U.S. versus Singh, the Fourth Circuit ruled that a malicious motive or greed are not required to convict a practitioner under the law. The federal government takes the position that the physician's documentation, and therefore the legitimate medical purpose, for prescribing and treating should be evaluated in view of the doctor's overall approach to treatment, not on one incident where the doctor may have been having a bad day or lost the dictation or some other reasonable explanation. As to privacy and security, controlled substances must be maintained in a safe or steel cabinet, and it is advisable to keep the prescription pads securely locked as well. And the drugs and records should not be readily accessible. Limit them and be sure to conduct background investigations on your personnel. There are DEA registration reports that are required when there is theft and loss, when there is destruction of drugs, or modification of your registration, or if there's a change of address or change of name or business is gone, and renewal applications. Now, what about the major problems that doctors confront with? Number one, doctor shoppers, forged prescriptions, excessive or unauthorized use, prescribing, unauthorized purchasing, and internet prescribing. When government agents investigate the doctor's records to look for doctor shoppers, they look for the following things. Are the symptoms incompatible with the reported injury? Maybe the patient is visiting the physician some distance from home. There is a history of problems, but no medical records to substantiate those records. The patient has multiple accidents. The patient insists on a particular drug of choice. The patient, as you heard earlier, claims loss of the prescription or medication. The patient fails to provide or go for medical testing. Or the patient takes more medicine than directed, requests meds early, uses medications from multiple physicians, and uses medications that are prescribed by others. And here's where the prescription monitoring program becomes important. The patient may use, as you heard, combination with alcohol medications, or uses prescriptions filled at multiple pharmacies. That's what the agents look for. Now, government agents investigating doctors look for certain indicators of controlled substances, which will tell them about diversion. They ask such questions. Is the doctor providing an inordinately large number of prescriptions, controlled substances? Is he writing large numbers of prescriptions or more than one at any one time? Are the medical records lacking in physical examination? Is the physician telling the patient to go to different drugs to fill the prescriptions? You'd be surprised. Is the patient known to be delivering the drugs to others? And you heard that earlier. Is the doctor providing prescriptions that seem inconsistent with legitimate medical treatment, not related to the injury, and the physician sometimes uses slang that suggests perhaps that that doctor may not be really doing the right thing. So these are things that I'd like to give you examples of some egregious examples. Here's one patient, He came to the doctor and said, I need pain medicine. The doctor actually gave him Dilaudid, 4 milligrams, 240, and gave him also Xanax with it. A review of the records showed poor physical examination. There was no history. There were no recent old records, no thought process, and no diagnosis. Another patient came to the office visit complaining of back pain. The doctor gave him a Schedule II controlled substance. There was no exam of the back, no old records or diagnosis, and no thought process. Another patient came for an initial visit complaining of back pain. He said, I had back surgery. The doctors wrote, I do not have his surgical records. An exam he wrote, there was decreased range of motion at the lumbar spine, but the first treatment was given, OxyContin, 80 milligrams, and lower tabs, 10 milligrams. Now here's another one. The patient was getting a prescription only for oxycodone. The agents did the drug screen on this patient, and the toxicologist showed it was negative for oxycodone, but it was positive for, look how many, hydrocodone, hydromorphone, cocaine metabolites, and marijuana. Should the doctor have done drug screens? Now this is the complete notes in this chart, only the list of medications, nothing else. The doctor prescribed OxyContin in increasing dosage, beginning with half tablet of the 20 milligram size, increasing to 80 milligrams 6 per day in 4 doses. And the time interval of prescribing was 3 months. There was no examination, no record of pain relief. And the patient also received oxycodone, 15 milligrams, 100 per month. And the doctor was alternating the prescriptions. Now here is the good one. Patient received Dilaudid, 240 milligrams. The chart revealed no address, no date. The medication was given PRN. There was no legitimate purpose. That's what really the agents are looking for, and most of us here are not going to do that. So what should the doctor do to comply with the law? Doctors should document legitimate reason for prescribing. There should be analysis of the old medical records. There should be adequate history and physical examination. There should be at least a history of drug abuse, if there was any, supporting the x-rays. You've heard that before. Test results. There should be continued re-evaluation of pain treatment, and we've heard also about that importance of ADLs and other methods of evaluating. Be sure you document your treatment plan. What are you trying to accomplish? And be sure to note patient compliance or non-compliance with medications. Should also include amount of controlled substances prescribed, the amount that is used since the last visit, the amount of dosages remaining at the time interval since the last visit, and outcome data. Please remember, outcome data, very critical to note that there has been improvement in function and quality of life, or ADLs. And if there is any evidence of abuse of the diversion, it should be noted in the chart. There are other recommendations that you might consider. Sign a pain agreement. Call it a contract or whatever else, but it is an agreement. It's a bilateral agreement. Conduct the pill testing counts, as well as do the drug testing any way you want to, whether it's by DICE method or any other method you like, and adhere to the important regulations by the State Medical Board. We're going to talk about the issues that are involved in medical malpractice. Here, there are a few things that you need to remember about medical malpractice. One is that there is a duty to establish a physician-patient relationship. In Oklahoma, in order to establish a physician-patient relationship with respect to opioids, it should be a face-to-face contact. You have to see the patient. I have not figured out whether face-to-face includes being on Skype, talking to the patient, and seeing him on video. I don't think this has been litigated yet, but it should come out sometime. There are people that have difficulty coming to the doctor. It's almost impossible, and you may need to communicate with them through some other means, and certainly a Skype or UVO or any of these methods where you can involve face-to-face contact is a good method, I think, but this is not accepted. It has to be person-to-person at the present time in Oklahoma. The informed consent sometimes is confused with the treatment agreement. By the way, there are, many of you may hear about that in the future, but there is a bilateral agreement where the doctor is entering into an agreement with the patient that is one-on-one. That is a bilateral agreement. Well, what if you send a patient to a specialist? What would the specialist do? Well, if you are in California, one of the clinics at UC Davis, they do what is called a trilateral agreement. Here what happens is that they recognize that the medications, the pain medications, are going to be administered primarily by the family physician and the pain management specialist. We really don't have enough of them in the first place, but they do want to work with the family physician. So they enter into what is known as a trilateral agreement, where they involve the two physicians, specialists, and the family physician, and the patient. And they agree amongst them how they're going to handle that patient. That's a very good method. I don't think it's used very much, but it is available. It's been used for over 10 years. It is available in the literature for you to look at. The next one is the documentation and medical record. Now, we talked about documentation in terms of demonstrating legitimate use as far as the federal regulation, but documentation as such is a legal requirement. We have to document, no matter, regardless what we are treating with. There is also a duty to treat appropriately. There are lawsuits currently that have shown that lack of treatment, under-treatment, and over-treatment leads to civil liability. And there have been cases, and now we're having more cases on pain management. Then we have the duty to consult. The duty to consult is important, particularly when you are seeing a patient who's being treated for pain, and you get your follow-up, and you find that the patient is really not getting help, or maybe even getting worse. Now, what are you going to do? You're not going to just simply increase the medication. It is important, particularly in a complicated case that has psychiatric problems, as an example, to refer that patient to a pain specialist and make sure that the treatment is being optimized, rather than, I think Dr. Anthony mentioned to us, sometimes giving them more medication actually may make them worse, so you're not sure. You want to follow them carefully and document improvement. Addicts differ from regular patients who are not addicts in one respect. Addicts, when they take opioids, their function worsens. Patients, you are trying to get them to improve their function. Patients on opioids that are getting help and reducing, say, their pain scale from 8 or 9 down to about 5 or 6, you rarely eliminate pain, but when they improve, you will see an improvement in their function. You can keep that in mind. You may detect a few addicts because they get worse and worse when they take medications and not better. And that's a good differential of the two. You have to document accurately. We are under a duty to document the diagnosis, what tests we are using, so you have to code correctly, and there is, of course, the HIPAA privacy and security which regulations that I think most of you are aware of.